Oh, I'm sorry, what did you say?
My girlfriend works in the Northwest. That's what I did. I'm like, I can't do real quick. It's a couple hour catered last time.
Oh, wait.
I'm for you, and I'm so disappointed that she didn't have all the big well, she like think her mom would put in her
I haven't looked at it yet.
Okay, any updates, pictures?
I will definitely send you. It's most of the pictures are ahead.
Ever on the web.
Yeah.
We'll move forward. Yeah. You need a chair there.
This one is yours. You know, I think it's
Yeah, it's yours. How do you pick the first time it's mine? Picture.
It was good.
Picture.
Pop right there, about a 45-degree angle.
Good afternoon, people, and welcome to our first session in the capacious setting of the Sheikh Zayed Medical Center in the Chevy Chase Auditorium. So we're very excited to be having our year in this hall, which has capacity for hundreds, thousands. But we are thrilled to have as our inaugural speaker, John Loonsk, kind of inaugurating the area of population health informatics, and so we're happy to be co-sponsoring this session with the Center for Public Health IT. John and I have been working together in AMIA for a number of years and public health informatics for a number of years. It's great to be bringing him here. He received his medical training at the State University of Buffalo, State University of New York at Buffalo, after graduating from Johns Hopkins, so he was telling me he and his family have rich connections to Johns Hopkins. He'll tell you more about his sojourn through different positions because it's relevant to his topic, but I just will highlight that he was instrumental in architecting the National Electronic Disease Surveillance System many years ago and initiating the BioSense program, which was really a hallmark in the 2000s which really was instrumental in bringing public health informatics into awareness nationally. He was so that preparedness activity was important during the anthrax attacks, West Nile disease beginnings, SARS, and Hurricane Katrina. So the environment that he put together for population public health was really has served the public well. He's a fellow at the American College of Medical Informatics. He co-chairs the eHealth Connecting Committee Council and is the incoming chair of the Public Health Informatics Working Group at AMIA. Take it away.
Thank you, Harold. And good afternoon, everyone. I'm very pleased to be here. As Harold said, I have a number of Johns Hopkins ties. My newest tie is that my daughter has just entered as a freshman on the Homewood campus. So I mentioned that I give to Hopkins a lot every day and appreciate the fact that I know what I'm talking about. I have a disclosure. I work for CGI Federal. It's a consulting and systems firm around the Washington Beltway. And today I'm going to talk about these objectives. I'm going to talk about patient outcomes and population outcomes, and about policy changes, and about informatics challenges and best practices. Harold suggested that I should give examples where I can, which I tend to be an abstract speaker, but if I am too abstract, please challenge me, question me. I'd much rather have an interactive session than just a lecture, so hopefully you will participate as well. Harold mentioned a little bit about my background, but I want to talk about it as well because it definitely provides a perspective on where I have been and what I bring to the discussion of health IT policy and of this whole activity. I went to medical school with the intent of being involved in health IT. It was sort of before informatics was well known, if it is well known as a discipline. And then my first real job was in an academic medical center at the University of North Carolina, Chapel Hill. I actually worked in Buffalo as well after I finished my training there. But I have seen academic medical centers. I have seen hospitals. I have seen clinical IT. I know what the challenges are in that environment. And then I was recruited to a position at in the National Center for Infectious Diseases at the CDC. And very soon after that, West Nile hit in New York City. And someone came into my office and said, we need to build a database of birds, of dead birds. And I just had no context for what they were talking about, but soon learned what that meant and what was involved. And for those of you who haven't been in public health frequently sort of tracks time by emergencies. There are periods of quiet, periods of intense activity, and I, fortunately or unfortunately, lived through a number of them. So after I was in NCID for about a year, I went to a position at the CDC-wide level as Associate Director for Informatics, and then the anthrax attacks occurred. And the anthrax attacks for public health were truly revolutionary. They turned public health upside down, certainly from the practice of public health standpoint, changed. Clearly, IT was involved, but IT was not really that helpful to the activity because of its state. And I can talk more about that as we go. And after anthrax, I experienced monkeypox and the smallpox vaccination program, which was not a huge success outside of in terms of clinical care, but it was a major endeavor. And SARS and then Katrina, and each one of them represented a different aspect of health IT infrastructure that was really necessary. It was clearly spoke to us about what we needed. We were going to be prepared to deal with those kinds of emergencies in the future, and very much from a population perspective. I then moved from there to become Director of Interoperability and Standards in the Office of National Coordinator. This is the office that was developed by David Brailer to roll out electronic health records and health IT for the country. And I was in one of the initial crews there in the last administration working on that effort. Began the Nationwide Health Information Network activity there. A major learning there was about the entrenched interests in health, whether it be the hospital associations, the clinicians associations, the technology associations, a real important exposure to how our health infrastructure works and where policies are active. And then I joined the private sector and became very clear how alignment of incentives was important moving forward. So I say all this to you so you get a perspective on this provocative thesis I'm going to provide to you, which is that to improve morbidity and mortality, we should be investing in population and public health technology over clinical care technology, hands down. That the government has an implied social contract to support population health. There is really no other business model that takes care of population health and public health needs completely. Whereas there is a business model for health care, the business model for public health and a lot of population health activities actually emanates from government. and that's essentially a contract with the population, the public, to do that. That right now, though we're investing upwards of $30 billion in health IT, that investment does not really address population health needs, even those needs that are seen evident for Accountable Care and Affordable Care Act. And that indeed, with some population modifications, if we think about population issues to a greater degree and put them in place in our policy, we can support better health outcomes sooner than if we don't. So that's my thesis. That's what I'm going to try to convince you of, and that's partly my perspective and why I come to where I come from to get there. So you've probably seen pieces of this before, that if you think about population and public health technology, it really spans quite a breadth. I think the starting place probably is the toilet, and it moves up from there. But from the standpoint of technology and outcome, it's hard to beat sanitation. It's hard to beat insecticides and spraying. It's hard to beat things like bed nets for other ways of delivering those. It's hard to beat vaccinations. And that now we are migrating into a new world where the technologies are more information technology oriented as well. And that these are by no means the only public health or population health technologies, but mobile health plays a much more prominent role in a population scenario. Social media potentially can have a greater impact in a population context than it can in a clinical care context. Case management, if you look at what a lot of those who are doing accountable care organizations or accountable care-like activities, a lot of it involves managing a case, seeing why an appointment was missed, reaching out to that patient, getting them re-engaged in the health system. And the big one is population data analysis and being able to bring together the data that are beginning to come available from electronic health records and other electronic information systems, and to use them for population and public health benefits. It is fair to say that high tech, this is part of the stimulus legislation. I think you all probably have had exposure to the fact that the government is investing anywhere up to $32 billion in electronic health records. So either hospitals or community providers can implement an electronic health record and get funded to do that by this high-tech legislation. But partly as an outgrowth of that, the comparative funding of clinical care and EHR technology and population public health technology is essentially at about a 1,000-to-1 ratio. So right now, the biggest policy activity around health IT is funding clinical technology and EHRs 1,000-to-1 at about 1,000-to-1 level over public health.
Isn't the government's investment in clinical care in relation to public health also matched about 1,000-to-1? If you look at the HHS budget, or it's like several hundred to 1.
It's not inconceivable. And not to mention the fact that the Veterans Administration, the Department of Defense are huge healthcare providers themselves. They contract with private healthcare to cover people in a massive way. People have estimated that government touches over 40% of all healthcare in the country in terms of its day-to-day activities.
25 or 50 to 1, something like that. That's how you define it.
So
Thank you.
this is still a lot. This is still out of proportion.
1,000 to 1. And that's a rough estimate. So, but there are issues here. There are policy issues. And so I'm being provocative in terms of expressing the magnitude of the investment difference. But one of the biggest ones, and the one that I think is very prominent in the current administration, is identifiable data and concerns about what is done with a patient's data, who has access to it, how those data are protected, and such. And so I put this here that aggregated identifiable data are an important consideration, as much to just put that on the table and set that as a target. Certainly not all population and public health activities need identifiable data, but many do, and many outcomes are tied to that. And that's partly where the challenge is. And there's a pretty direct relationship, pretty direct clash between data access and data protection and data lockup when it comes to some of these outcomes. So from the standpoint of patient care, if you want data to follow the patient, a laudable goal, to be wherever the patient is receiving care, you need to move those data. Those data need to move. They need to be accessible to the right people in the right context. So I'm contrasting data access and data lockup, or where the data are not accessible, they're locked up, and in the extreme case, can't be accessed for whatever purpose. The concepts of medical homes, longitudinal records, continuity of care, these are all about getting patient data in the right place so they can be accessed by providers to use for their own purposes, for their appropriate purposes of providing care. Obviously, payment and operations is another major data user, and perhaps accesses more data than people are even aware of from the standpoint of the payment process. But there are also population uses that need data, public health, healthcare quality and efficiency, health research. There are obviously needs for law enforcement as well. And on the lockup side, what's driving toward locking those data up, one of the top ones is the business proprietary nature of the data. So it's not necessarily protecting the patient, although that's obviously prominent too, but it's frequently protecting the provider from, in terms of both competition in healthcare and in terms of the challenges they face by making data available, the legal challenges, the complexity, the opening of the door to challenge when data become accessible. In a litigious environment, it's always easier to be conservative about who accesses the data than to be freer and releasing of those data and allowing people to access them. The paper aspects of the medical record are obviously an obstacle to data access. The complexity, the diversity of provider models. Healthcare in delivery is extremely variable in this country, and that variability makes for complexity in terms of getting data out, because the different approaches provide challenges, if only because they're different. And then there are obviously very legitimate concerns for patient privacy, for concerns for insurance and employment if the information was available in the wrong way. Some of these are attempted to be addressed in the Affordable Care Act. Almost universally, people respond badly to the commercialization of patient data, so they don't, want to get an email flyer talking about their medical condition in their mailbox, suggesting that this drug or that drug would work well for their particular condition. That is anathema to them. There have been problems historically with implementing HIPAA. Of late, this has changed, but HIPAA is the regulation, the national regulation for how data are protected, and the enforcement of HIPAA was historically very weak. There were very few cases brought, and so it was not well supported. And there's a very great diversity of state laws and practices. So like the diversity in clinical care, the diversity in states becomes a very big challenge for how to access data. If Minnesota is conservative in how they release data, even for clinical care purposes, and Rhode Island is more liberal, if you're moving from Minnesota to Rhode Island, it becomes a complex issue, partly because of the difference in their state laws, and partly just because they're different and because it's complex and because people are conservative when it comes to how they apply this and work through the issues. And I would also propose to you that there's a major driver for locking up data, which is around fear, uncertainty, and doubt that is expressed, and that there are people that profit from that. There is a legitimate privacy industry, and there are also people who very much do well for themselves by riding the fear, uncertainty, and doubt about the way in which clinical data, patient data, could become a problem if it was to work its way out. So if I've expressed the tension between privacy and confidentiality and patient care and population uses, that's only a part of this complexity. I talked about fear, uncertainty, and doubt, business proprietary data. There are also the misaligned incentives that I alluded to. There's a really awkward public discourse about this as well. It's not something that government and policymakers can talk about in public settings very readily. It's hard, partly because of the way in which discussions can be inflamed if taken out of context. There's also a tension between the idea of policy and regulation as a tool to manage this, and technology and security as another kind of tool, and where to draw the line between them. So is the security of patient data to be made manifest by putting people in jail when they misuse it? Or is it to be made manifest by using secured tokens and technical infrastructure that precludes them from accessing them to begin with? Or is it some combination of the two? Clearly. And where does that line get drawn? And that becomes very complicated. You have policy people, you have technology people, and a difficult discussion to carry that out. There are other traditional health IT obstacles. For those of you who might wonder why $30 to $32 billion is necessary to move health IT forward, part of it has been that it hasn't been attractive to most clinicians to use health IT, to use EHRs, for a variety of reasons, aside from the data privacy and security issues. The technology has not been well formed for clinical workflow. A big PC sitting locked against a wall in an exam room is not a great model for technology implementation in care. Now that's getting better. Mobile technology, tablets, phones, and such are an improvement over that model, but the ideas of clinical workflow, how the technology changes clinical workflow, what it implies both literally and tangibly to clinicians, what it implies from a fear and uncertainty and doubt standpoint from clinicians who fear that it will impede their ability to practice care, will add time to their care, or will make their care in what is frequently considered not a very stimulating environment, or I should say a highly constrained clinical environment and care environment, that much more constrained with the technology as the tool to tell them what to do instead of allowing them to practice. There's also a major issues about getting the provider to actually getting access to their attention, and I'll talk about those a little bit. I mentioned the misaligned incentives. There are also huge interoperability issues in terms of moving health information. Health information is a very complex information space. It's not the same as billing data. It's not the same as standards for many other industries because of the complexity of the information, the complexity of the content that needs to be expressed, that needs to be conveyed from one system to another, from one provider to another in a reliable way. So in that environment, if you're convinced that health IT can help, what are the policy tools that you can use in that regard? Well, obviously there's leadership. That was essentially the tool we had when I was in the Office of National Coordinator. We had a $65 million budget, which was by today's standards trivial at a national level. And certainly in comparison to $30 billion and the $2 billion or so that was basically available to the subsequent administration. There's law and regulation, although I think it's overblown as a tool on policy side. There's the specifics of funding, and obviously high tech is a major part of that. The Affordable Care Act is a major player here. And then there are health-related programs, and they play a bigger role than many people think. I mentioned before that the VA and the DoD are major purchasers of healthcare in addition to major providers of healthcare. But think of all the health programs that the federal government and state governments advance, whether it be Medicare, Medicaid, the new health insurance exchanges that are being promoted, the technology for quality reporting, public health systems like those for the National Electronic Disease Surveillance System or the Public Health Information Network, on and on and on. There are programs that are advanced to try to change the way in which technology is used for better outcomes. One of the newer activities that I would suggest has happened in this administration is they've actually used technical standards as a tool for policy implementation. So actually IT standards used as a way of advancing the policy of health IT. And I'll talk about that in a minute. So right now, the current pillars, if you will, the major components of health IT policy, using those tools, what are they doing? What is being advanced? I would propose are these. One, an EHR focus. So very EHR oriented. Electronic health records, really electronic medical records would be the more appropriate term. It's really about funding software systems that support the provision of health care. Two, clinical decision support. And I'll talk about each of these. Three, EHR-initiated quality reporting. So getting quality measures out and using EHRs as a facilitator of that, because that's a really onerous activity. And if quality measurement is an important part of pay for performance in healthcare, which is a part of the direction that health reform needs to go, then if you draw back on that, you need to go forward with, you want to go forward with health reform, you need to do, you want to do pay for performance, you want to pay for quality more than quantity of care, you need to be able to measure the care. And it's very challenging, onerous to pursue. EHRs, health IT, is offered forth as one way of getting out of the onerous aspects of quality reporting, or at least reducing them. And then health information exchange, what I've alluded to previously. How does the health information flow, and to what degree are we facilitating that flow to achieve our outcomes? So first, the EHR focus. I would say that right now, and I've said this several times, that the massive government investment is specifically focused on electronic health records, electronic medical records, software systems that are used to support the provision of care. The investment was really sold on two big hopes. One was that this investment would ultimately reduce healthcare costs, and that this technology infrastructure, along the lines of what I just said about quality measurement, was important for health reform. So if we want to do health reform as a country, we need technology to advance that. The problems, some of them I've alluded to. The EHRs support practice-specific care. It's a provider's office or a hospital implementing a software system to support the transactional care that's carried out there. It's usually walled off organizationally as a system. The organizational unit that buys that software system and implements it, and implements that database of patient data, is defined by that practice or that hospital. So what that puts a large emphasis on is if you're thinking about outcomes that are dependent on data moving in different ways, not necessarily just residing in that practice or in that hospital, you have to think about interoperability from those EHRs. How do those data move? So this emphasis on EHRs as a focus is very much puts an emphasis on inter-EHR interoperability, the movement of data from one EHR to another or to another database somewhere. And that's very challenging. I alluded to that before, that the interoperability is challenging in health space, partly because it's a complicated information space, and partly because the legal environment has made it undesirable. The business environment has made it less desirable to actually share information between practices. There have not been compelling reasons to drive interoperability, and without those compelling reasons to share, the accumulation of reasons not to share has largely overwhelmed them. Another problem you may have just seen in the press, this has caused the email lists on a number of organizations that Harold and I are, and others here I'm sure are on, to light up, which is the study that said that basically EHRs increase the cost of care because they're more efficient at Medicaid payment reimbursement. So in other words, by virtue of the technology, the first thing out of the gate, if you will, is that, oh, the technology is making it more efficient, but what is first focused on is capturing better reimbursement from Medicaid patients, and that this is substantiated. So that rocks the policy world. You know, that's as an issue to be coped with. So my first thesis here would be that there are population refinements we can make on this overall picture. And one of them is that a focus on the data rather than the software, a focus on the data about the patient rather than the software system that is the EHR that's implemented in that clinical setting, which is what the current focus is, could be beneficial to reducing some of these issues. Another focus could be more discussion on the promotion of non-practice-oriented data stores. There are several ways this can be done, but there's very little discussion of how these aggregations of data outside of the immediate provider's office or the immediate hospital setting are being advanced. Very little policy discussion, partly because of the challenges that I've alluded to before. Number two, clinical decision support. So this is the major outcome-oriented tool. So if you will, quality measurement's important for the reasons I said before. If you want to do health reform, you need to be able to measure quality so you can tell when quality changes in healthcare. But if there is a effector tool here that is associated with health information technology, and particularly in EHRs, it's clinical decision support. And this is that in the context of the provision of care, information is provided just at the right time, just at the right place, with the right context of the patient to change the way that care is provided. And the systems that do that are providing clinical decision support. Maybe it's a drug-drug interaction, so that you're in the process of, you are a provider and you're ordering a drug for your patient, and in the second you're clicking on that drug to try to order it, the drug-drug interaction is identified through the processing in the back. You're alerted because you're a provider and you're on that system and you're making that order, and you realize right then and there that that's not what you should do. That's sort of the gross characterization of what clinical decision support is. Obviously not just prescribing, but in all aspects of the provision of care. But there are problems here. And so one problem is that it really demands provider face time. So if I'm the provider and I order a drug for a patient, but I'm not putting it in on the system because a clerk is putting it in, then that alert that was telling someone that there was a drug-drug interaction comes to that clerk, not to me as the provider, and you've broken the chain. Now, obviously, theoretically, they could convey that information on, but this is one of the reasons from a policy standpoint that there's a lot of push to have the provider themselves be the one that's using the technology, is because of this conceptualization of clinical decision support, and that this is the tool that can affect the way to improve care. Another issue with clinical decision support is it's hardly standardized. With quality measures, when you try to do an electronic quality measure, every data element is highly specified. Every I is dotted, every T is crossed to say we want this numerator, this denominator, this exclusion. Everything is highly specified. And there are a lot of these that are now being advanced in the context of both the so-called meaningful use criteria for how you are eligible to receive your money for putting it in EHR, but also in the context of many, many CMS and other programs that are striving to get to quality measurement. In clinical decision support, it's not standardized almost at all. The way it's being advanced, and it too is in meaningful use as a requirement for getting EHR dollars, the way it's being described is do clinical decision support. This year you need to do 1 rule. Next year you need to do 5 rules. Those aren't the same rules that anyone else is doing, necessarily, but that's the level that it's being described in advance. So it's not very standardized at all, and the challenge with that is it's going to be very hard to take lessons learned from one environment and move them into another environment, because essentially when you've seen one rule implemented, you've seen one rule implemented. Here's the other bad news. Another recent study that also lit up the health IT email listservs basically said that as now implemented, clinical decision support helps advance process measures. So the specific process measure that may be being implemented is definitely improved, but it has minimal to no quantifiable health outcome. So that's obviously not a great thing. It is probably more about how things are implemented than the gross concept of what clinical decision support is. But in practice, there's not a lot of political tolerance from a policy level about saying, we don't need to see this investment, $32 billion, pay off now. We can see it pay off in 5 years. That doesn't work in the policy environment.
May I have your attention, please? May I have your attention, please? We will be conducting a test on the fire alarm system. Please disregard any audible or visual signal.
We're prepared. We're prepared.
I can readily disregard that. So there are concerns about the political tolerance, the tolerance when you're working in the policy environment and people have to show outcomes. If the first thing that's advanced is that it actually costs more to provide care when you're using electronic health records, and the second thing that's advanced is that, in fact, clinical decision support shows no immediate outcomes, that's not a good recipe for advancement. So one of the things that can be done in this regard, the whole concept of clinical decision support really is about, to use Harold's terms, an afferent and efferent arm of the technology. So afferent being the data coming to the processing, the data coming out of care, coming to the the algorithm that processes those data, and efferent being the effector arm, what action is taken, the alert or the reminder, and what isn't said here is the other great challenge with clinical decision support is that most providers of care really aren't too excited about receiving reminders on top of all their email and on top of all their other messages when they're particularly not well honed to their exact issue with a patient. So those reminders can be challenging. But if you think about clinical decision support as it's now articulated, it includes the afferent and efferent arms. It's a loop, and it has to get data out, it has to process it, and then it has to affect some sort of change. Well, a lot of this we've been doing by separating those two arms out. And from a population standpoint, thinking about not just...
Go back for a second.
Yeah.
I just wanted to ask about the last slide. I think there's a third bullet on changing who the user is. Right? So when you have a case manager,
yes,
you have actually face-to-face, you have closed loop decision support, but it's a person who's making a populational decision rather than an N of one decision.
And I think what I'm I totally agree. What I'm alluding to is a fully electronic loop, and which is sort of the basis of most people's conceptualization of clinical decision support, versus a loop where there's a population worker who receives information on patients and how on providers and how they do, and then takes that information as a human and advances a population program in the traditional way that those programs are advanced. So it's not an automated loop from data, context to effect. It's a loop where some of that is taken by a person, a population health worker, and then used to go speak with Dr. So-and-so and say, did you know that this is where you are in relationship to this, how many times you've tried to prescribe this medication or your use of this particular therapy? And that, in fact, that's the way most population health programs are carried out now. And what's challenging about clinical decision support is it's attempting to do both of those electronically now, when there are intermediate opportunities to get data electronically, provide them to population health workers, and then from an efferent arm standpoint, from an effector arm standpoint, to be able to use more traditional processes for improving the quality of care on their basis, and not necessarily having to interject into the clinical workflow to get that outcome. So thinking about population decision support, where patient-specific data is available, where best practices and policies are accessible, where studies, surveillance, and other information surveys can be accessed, where those tools can then, the data can be combined and stacked and sorted and provided to someone who analyzes them. That's a major task. It's a challenging task. It's being done in many different settings, in many different, to to many different degrees, but supporting population decision support as at least a bridging approach using EHR data and electronic technology offers promise over just implementing at the clinical decision support level, with the goal here of obviously having actionable information for programs. Number 3, EHR-initiated quality reporting. I think I've talked about a lot of this. With the quality reporting, this is a major emphasis of not just high-tech, but also ACA, but there are challenges here too. And there are opportunities to refine it to a practice-based approach versus just an individual, to a pan-practice approach versus just an individual provider approach. If you think about it, many of the desired outcomes of health reform come from quality reporting that is done at more of a population level than an individual practice level. Number 4, limited health information exchange. From a policy standpoint, what's being advocated right now is health information exchange that goes from one provider to another via secure email. This is the so-called direct approach. So it's initiated by the provider that has the data to send it to a provider that needs the data. The other flow that is being supported is the Blue Button initiative, which is where patients are allowed to get data downloads of their record. Now, both of these are laudable. The latter flow is obviously from provider to patient. Both of these are laudable activities. The problem is that they're fundamentally disaggregative. They are not about aggregating data. They do not facilitate aggregating data. They are non-accretive. And the push approach has, basically replicates existing fax workflows in clinical care, which by many are considered to be broken as they exist today. So how many times have the information that you wanted to reach a provider not been at that provider because the push was never initiated? The difference between push and pull from a policy standpoint is that with proper authorities, pulling allows your provider to get the data at the time that they need it versus just having to have had it pushed because that was initiated on the other side. The other challenge here from the Blue Button standpoint is that the PHR, the personal health record market, has not developed as people have hoped. So the idea of the consumer managing their health record in a independent software system where they would have ownership of their record, it's their record after all, and be able to use that to both convey it between providers and also to use it for their own personal care purposes has not, as a market, developed. Yes?
I was under the impression the money was starting to flow from the states to come up with their traditional plan for health information exchanges, that the old objectives were a lot more broad than the Blue Button direct push. And it really did focus on individual verification or allowing them to have access to say who does get it. And it seemed you met Chris visited say Maryland last week, and they came up with and now their goal for this. That's it. What happened with loftiness down?
So it's an excellent question. Oh, repeat the question. So the question is, in the past, has it not been articulated that the vision for health information exchange is broader than just push from one provider to another and download via Blue Button? And the answer to that is yes. In the past, that has been the case. The two outstanding challenges that have changed the posture, I would assert. So some of that posture still exists at the state level. Some of it still exists at a regional level. But it is not part of the national policy context. And it's not the way the funds are being executed.
Why?
And the one reason that's suggested is because the sustainability of independent organizations to carry out health information exchange is too challenging. So no one has wanted to have to foot the bill for health information exchanges in perpetuity. In some states, particularly smaller states, they put a tax on their the payment system, and they redirected those monies to their HIE, like Vermont, and they solved it. But for the majority of them, this has been sort of this onerous, repetitive conversation about sustainability that just, well, how can you make your business case? What services are you going to sell? How can you be compelling? And it's fundamentally difficult because many people have not really wanted to exchange information, so it's hard to sell them that capability as an outcome. But I would suggest, too, that the second reason is that and I'm not being judgmental, but that the privacy agenda of this administration is much stronger. And that these are the two information flows that they're really comfortable with, which are data going from a provider to a provider and data going from, and I'm talking about identifiable data, and there's obviously, I'm speaking in broad brush terms and all of that, and then data going to that to the patient from the provider. And when I said earlier that standards are now being used, technical standards as a tool of policy, this is one place where that's happening, because the regulation is not necessarily limiting this activity, but in terms of the funding and in terms of their emphasis on what standards are being advanced and putting to meaningful use and advanced through that lever, which is a powerful lever to try to advance it nationally, this is what they're advancing, these two thrusts. And I think that the privacy issues are a compelling piece for them as to why they're not advancing pull with nearly the same emphasis, if at all. So, and it's really toward my last point here, that the population refinement of health information exchange is really to enable technologies that can bring data together that are more aggregative than disaggregative. And it's challenging, it's complex, there are all kinds of issues with it, but it fundamentally happens for your payment data. So the payment system can accomplish it. Why is the population, the quality, the public health system a second-tier candidate relative to their ability to choose some of these same approaches? Unfortunately, and when I alluded to the awkward public conversation, I find the conversation to be frequently about identifiable data staying with the provider and de-identified data being provided to other uses. And that's a vast oversimplification of what is necessary to support these kinds of activities moving forward. So, finally, I just want to point out that we're really at an interesting point around all of these issues. On the one hand, we have high tech. This is the stimulus legislation. This is the EHR push. It's very technology oriented. It's about electronic health records. It's by virtue of that, it's about transactions of care. It's about health care versus the more population-oriented activities. There is meaningful use, which is trying to basically make those practices better, and some of those, to be fair, also include a smattering of population health activities. For example, EHRs are now expected to be able to list all of their patients that have a particular disease. This in the first round of meaningful use, that was the requirement, that you be able to make one list in your EHR of the patients with the disease instead of looking at them as on a case-by-case transactional basis, be able to list everyone like that. Setting specific quality measurement. High tech being sold as supporting the Affordable Care Act and health reform, but in health reform, which also is a massive amount of money to advance it, has some population health orientation around pay for performance, around more prevention, around cross-practice population. There's no technology constraints. The Affordable Care Act is business-driven, not technology-specified. High-tech, technology-specified, but very much oriented to sort of the EHR world and the transactions of care that we're trying to move away from. So this is an opportunity for advancing population and public health moving forward, but one that is yet to be really made manifest. So thank you for your attention.
Listen.
Yes. So my question is, do you think it's time when a patient becomes a more active participant in their own health care through being seen as the end user of the EHR or perhaps the owner of their own EHR? Or do you ever see a component of the EHR facilitating prevention of becoming a patient? I see in here, and you're a patient this, and you're a patient will do that, and there's so much focus on once you're a patient, and there's almost no focus on, hey, that's what you might be able to prevent becoming a patient. So what does your vision see for those things?
I have to repeat that question. So the question was about PHRs, and will there be a role for patients to be more active in their own health care by virtue of PHRs, and also more active in prevention by virtue of having technology and PHRs. And I think a lot of us hold that hope and see that as a possibility. If you think about what health reform is, accountable care is trying to make the provider of care responsible for the quality and the efficiency of care. Previous efforts have tried to make the patient responsible by transparency of data access and of making choice so the patient can make choices. Where should I go? Should I go to Hopkins or should I go to MedStar? Can I mention that? But it's really hard, and efforts in that regard of making health decisions on the basis of that kind of data have, some have been successful, but many have not been. Specifically on the PHR side, I mean, the blue button effort is to try to get data to PHRs. A number of companies have made major investments in PHR technology, including Google, Microsoft, and a slew of other smaller companies. Google has shut theirs down. Microsoft won't tell how many people use it, their PHR. And part of it's because the health information is hard to exchange, it's complicated, and it's variable. But part of it is because patients have really not grabbed on to holding those data for themselves. If there is a PHR area that is taking off, and they're still called PHRs, it's the patient portal. So Hopkins has a website where a patient can see their own data, see their lab results, schedule their encounters. That is a burgeoning area, but it's really a view on the provider, not a totally untethered, unconnected environment. So one might hope that eventually with time, the technologies stop being the obstacle in terms of the patients being able to access their data, but it has to be proven essentially that they will want to do that. From a prevention standpoint, there are great many opportunities, and they're starting to come forward in things like Text for Baby and other social media, where if everyone has a mobile phone, a smartphone, you have wonderful access to them from a communication standpoint, the kind of access that can potentially have significant impact on outcomes. And I think people are just very enthusiastic about doing them. And moving forward in that regard, I will point out that a recent study on using social media for prevention purposes found that over 60% of the prevention messages that were being advanced through social media did not meet the current guidelines for what was being is recommended. So we still got work to do there too.
So the first time, thank you for the presentation. I really like that. You mentioned a privacy industry that was actively opposed to the sharing of information, that they somehow benefited from this as a business model. And so that kind of got the conspiracy theorists to keep going. I'm all excited for it. Is that something that you could expound upon? Is that like just the ACLU, or is that like hospital associations, or is it medical associations, or is it just a malpractice thing? You got me going there.
So the question was about the privacy industry and whether there really was a some wing conspiracy about making privacy more pervasive. Since the conspiracy theorists are all on top of the fact that the government wants everyone's data, health data for every purpose, I think it's only appropriate that we inspire other conspiracy theorists who argue the other side. I wish I could say that it was quite a conspiracy. I think it's more of a loose-knit group of individuals who may come from the right place at times, but have definitely done well by heightening concerns. And I'm thinking of specific individuals who are known policy people who are quite willing to use hyperbole in terms of concerns and risks in a awkward conversation that really begs for less emotionalism. So I don't personally think that there's a conspiracy. I do think that and I'm aware of a number of different groups that have done very well for themselves in terms of their objectives of their organization and their individual personal reimbursement on the basis of being on the fringe of privacy concerns.
And you are talking about the efforts, health funding versus clinical care. I was thinking about, in the end, you need, though, to have all that data electronically available to start making public health decisions and get public health information. So I'm seeing this first step as actually capturing the data electronically using meaningful use to establish a base and then move on forward. So doesn't it make sense there would be more effort in clinical care versus the public health?
So the question was, shouldn't the emphasis be on clinical care capturing of data so that, because that's necessary to get to the use of data? And I think kudos go to the current administration for trying to put coded terminologies into meaningful use as a goal for capturing data, because there has been so much resistance to that in the past. When I was in Health and Human Services in the office in ONC, we couldn't talk about things inside the firewall, so to speak. We couldn't advance them because there was just so much pushback on standardizing the coding of clinical data, which is along the lines of what you want. And particularly if you're looking at a cross-practice population, you want them well standardized. You don't want them to be apples and oranges if you're going to do it. So there has been, but it's a very complex area, and the progress with those standards has been very slow of actually implementing them because of a variety of different challenges. So my proposal is we need to do both. And there is a whole area, whether you call it observational research or situational awareness and syndromic surveillance or biosurveillance in public health, where it's basically the approach is take the data you can get and try to use them to your purpose versus, the historical case report in public health, which is, highly specified, highly detailed, And basically people want all those data in exactly that form, or they don't want the they don't essentially want the data. So I think there are opportunities to do more in the observational domain as well, even while the data are not completely standardized. And I have to say that from my experience in public health, being associated with the number of emergencies, we really needed those data. I mean, if we had data on emergency room, even pretty simple data on who was being admitted to emergency rooms for what purpose during the anthrax attacks, would have been extremely helpful. Just because there were postal workers coming in with cutaneous lesions, and and it was not known, and that was never put together. And so, I think there's a rule for both, an opportunity for both, and I think that the data will never be exactly the way we want them. Getting them into purely standardized form is going to take some time as well. Part of the problem is that it's, the public health also needs named data at times, and, it's sort of something that's not frequently talked about in the policy circles inside the Beltway, but, local and state public health absolutely need to get a reportable disease data in named form, and when there's an outbreak, an emergency, all bets are off in terms of who needs those data and how they have to access them.
Let's thank John for we have to come down and come back with the